Coming to the pharmacology of Parkinson disease. Before knowing the pharmacology of the Parkinson disease, we should know what the things we should learn in the pharmacology of Parkinson disease. In the Parkinson disease, we have to learn the high yielding points are classification and all the drug names, basic properties of all the drugs, side effects of all the drugs, basic knowledge about wearing of phenomenon, which is a very big challenge to the clinicians. Most must to know some pharmacological facts in the Parkinson disease therapy. Coming to the dopamine receptors in the Parkinson disease, first we should learn about the dopamine receptors. The dopamine receptors are particularly 5 types: 1, 2, 3, 4, 5. Of these 5 types of receptors, dopamine 1 receptor, dopamine 2 receptor are present in the striatum. Dopamine 4 receptor and dopamine 5 receptor are present mainly in extrastriatum. Based on the functioning of the dopamine receptors and the type and the dopamine, we classified dopamine receptors into two groups. Group 1 is D1 group, group 2 is D2 group. Coming to the D1 group, we see the dopamine receptors are D1 and D5. They act mainly associated with the GS type of receptors leading to cyclic AMP pathway. And the D2 group is having D2 receptor, D3 receptor, D4 type of receptors. They are associated with GI type of receptors. They decrease the activity of adenylyl cyclase and they decrease the voltage gated calcium currents. Coming to the pathophysiology of the Parkinson disease, there are many theories. Of those many theories, it is wise to follow this theory because most of the medications are and the therapies are designed believing this theory. Coming to the physiology, the dopamine is an inhibitory neurotransmitter. We can compare it with this red color train. Acetylcholine is an excitatory neurotransmitter which can correlate with this blue color train. These two trains are moving on opposite fashion on separate tracks. Dopamine acts on separate receptors, acetylcholine acts on separate receptors. But when they act on in reverse fashion, we have to compare the relative activity. Normally, in a healthy individual, both cannot cause any imbalance in the motor function in the patient, in the person. But in Parkinson disease, there will be relatively less activity of dopamine when compared to of acetylcholine. That is, dopamine activity is decreased, or acetylcholine excitatory neurotransmitter activity will be high in Parkinson disease, relatively more acetylcholine activity than dopamine activity. So while giving pharmacological therapy, we are concentrating on to boost up the dopamine. We give dopamine agonists. To decrease the excessive activity of acetylcholine, we give anticholinergic drugs. The clinical features of Parkinson disease, starting from mild to advanced. In the mild cases of Parkinson disease, we see mainly these are due to cholinergic abnormality. The clinical features we see are anosmia in the patient, and in the sleep, coming to the sleep pattern, we see REM sleeps are in more duration and frequency when compared to NREM sleep. And behavior disorders are also starting in this non-motor feature, which is seen in mild stage. Constipation is also most often ignored clinical feature. The treatment modality in this stage is exercise and lifestyle intervention. When the disease worsens further, in the intermediate phase, we see the motor functions, motor features abnormalities. These are mainly due to dopaminergic imbalance. The clinical features we see in this stage are bradykinesia, muscular rigidity, and resting tremors, impairment of postural balance. When the disease worsens further, we see again cholinergic abnormalities like depression, anxiety, dementia, cognitive impairment, hallucinations, delusions, and executive and visuospatial dysfunctions. In total, there are 7 groups of drugs to be kept in mind while learning the pharmacotherapy of Parkinson disease. First group is combination of levodopa and carbidopa, combination of levodopa and benserazide. Second group is dopamine receptor agonists. Again, there will be ergo derivatives and non-ergo derivatives. The third group is COMT inhibitors. We are going to study all these drugs in detail in further slides. Fourth group is selective MAO-B inhibitors. Fifth group is muscarinic receptor antagonists, trihexyphenidyl and benzohexal and benztropine and diphenhydramine. Sixth group is the samantidine. It is a weak NMDA receptor antagonist, non-competitive, and adenosine A2A receptor antagonist, istradefylline. First group, the levodopa therapy. Initially, levodopa is the first drug we discovered for the treatment of Parkinson disease because dopamine as it per se, it cannot pass through blood-brain barrier. It is having no entry from blood to brain. So our target is to improve the levels of dopamine inside the brain. We have to design a drug which can be activated into dopamine after entering the brain. That drug is called levodopa drug. This levodopa drug can pass through blood-brain barrier. When after entering into the brain, dopa decarboxylase is an enzyme which converts drug levodopa to dopamine. The same dopa decarboxylase enzyme is present in blood also. If this enzyme is present in the blood, we call it as peripheral dopa decarboxylase. The enzyme which we see in the brain, we call it as central dopa decarboxylase. If the levodopa is activated to dopamine in the peripheral, that means in the periphery, in the blood, we cannot achieve our challenge. We have to give more and more doses of levodopa. That's why we adapted certain drugs like carbidopa and benserazide. They have a tendency to inhibit mainly peripheral dopa decarboxylase. They cannot inhibit central dopa decarboxylase because they have very poor entry into the brain. If these compounds is having, if these compounds also having total entry into the brain, then we will be facing much more challenge. We are adding drug levodopa with carbidopa or benserazide to decrease the dose of levodopa so that we can give levodopa in very low doses to achieve our target. When this drug levodopa is metabolized into dopamine in the blood, it causes nausea and orthostatic hypotension. For this nausea, the treatment is domperidone. This domperidone, without affecting the efficacy of the drug levodopa, it can be used for avoiding treating this nausea. And some more points we should remember about this levodopa. As we know, it is a prodrug. It needs to be activated. Early Parkinson disease, if a patient is having early Parkinson's disease, we can see there will be a dramatic improvement in the motor signs when giving this levodopa. It will be very fine drug, but the main challenge with this is this wearing off phenomenon. It is the main side effect we see with this levodopa on giving on long term use. At least it takes some months to years to see this wearing off phenomenon and levodopa induced dyskinesis. The meaning of this wearing off phenomenon is, for example, if you are giving this levodopa therapy, initially the patient will be having good signs. That means there is relief of symptoms. We call it as on. But after few years, we see the patient will be fine, but suddenly we see just like the drug is not working. We call it as off. Again, the patient will feel improvement of the clinical features. We call it as on. Our basic target is to maintain the patient on. Our basic target is to avoid this off phenomenon, to decrease the amplitude of this off phenomenon, and to decrease the frequency of the off phenomenon. On off phenomenon, we keep on seeing this on off. Our target is to decrease the incidence and the frequency of this off phenomenon and the duration of this off phenomenon. It is the main challenge while treating Parkinsonism disease. New formulations to improve wearing of phenomenon. For this wearing of phenomenon, we tried many other drugs, but regarding this levodopa, we tried some other types of formulations. First type is levodopa carbidopa extended release capsules. It means in a single capsule, if we see, we can see small minute beads. Of those beads, some of the beads will be like immediate acting beads. Some of the beads will be extended release type of beads, so that we can decrease this frequency and duration of this off phenomenon. And we designed another two technique also. Second technique is a surgical procedure. In this levodopa carbidopa combination is implanted as an intestinal gel. It is surgical procedure. Third one is levodopa inhalational powder. And adverse effects of levodopa, what we should remember mainly are levodopa induced psychosis in elderly patients, characterized by hallucinations and confusion, and impulse control disorders, we call it as ICDs. Abrupt withdrawal of levodopa, it causes neuroleptic malignant syndrome. It is a lethal clinical feature we see after giving in the levodopa when we suddenly stop giving levodopa. Abrupt withdrawal. It is lethal and clinical features are confusion, rigidity and hyperthermia. Fatigue and somnolence is the very common side effect which is complained by the patients taking levodopa. And important drug interactions of the levodopa are levodopa when combined with non-specific MAO inhibitors, it causes hyperpyrexia and hypertensive crisis. The problem is this hypertensive crisis is life-threatening. That's why in the pharmacotherapy of Parkinson disease, we adopt MAO B selective type of inhibitors instead of giving non-specific, non-selective MAO inhibitors. Levodopa and MAO B inhibitors, when combined, they are safe. Levodopa to be taken at least 1 hour before meal, because in the routine meals we take, proteins will be there, they compete with the absorption of the levodopa. Pyridoxine is vitamin B6, which is a cofactor for peripheral decarboxylase enzyme. Eventually, it decreases the efficacy of the drug levodopa. That's why while giving any multivitamin supplements to Parkinson disease patient, we have to make sure pyridoxine is avoided. Dopamine receptor agonists, they can be used as monotherapy or combination with low dose levodopa. These dopamine receptor agonists are two types, ergo derivatives and non-ergo derivatives. Coming to the ergo derivatives, D2 agonists are bromocriptine. They are used in low doses to prevent valvular heart disease. Other side effects are peripheral vasospasm, retroperitoneal fibrosis. Pergolide is another drug which is banned nowadays in US FDA because it causes valvular heart disease due to stimulation of these 5-HT2B receptors. And we can see some rotigotine transdermal patches. It is a non-ergo derivative. It acts on D2. And some D3 agonists are pramipexole. Pramipexole acts on the other types of dopamine receptors also. These also act on other types of dopamine receptors. But dropenerol and rotigotine has more affinity for D2 type of receptor. Pramipexole is having more affinity for D3 type of receptor. These drugs are particularly effective in treating off phenomena. Side effect of these dopamine receptor agonists are hallucinations, nausea, orthostatic hypotension. That's why while prescribing dopamine agonist, we should administer with start with very low dose therapy, and we should keep on going titrating the dose, increasing the dose slowly. Fatigue and somnolence is the side effect, most common side effect we see with this dopamine receptor agonists. Coming to D4 agonist apomorphine, initially it is used as sublingual tablet, but the sublingual tablet caused many oral ulcers, and that's why we adopted subcutaneous injection. Use of this apomorphine injection is it is used as rescue therapy for acute off phenomenon, which is seen in levodopa therapy patients for a long-term use. Side effects of this apomorphine injection are it causes QT prolongation and injection site reactions and abusive behavior with hallucinations and dyskinesias. This apomorphine injection is highly emetogenic, and to avoid this emetogenicity of this emesis due to this apomorphine injection, we have to start trimethylbenzamine tablet 300 mg thrice a day at least 3 days before starting the first dose of apomorphine injection. Apomorphine should not be combined with ondansetron to avoid emesis, because when they are combined, they lead to profound hypotension and loss of consciousness. Therefore, ondansetron, which comes under 5-HT3 antagonists group, are contraindicated when we are giving this apomorphine injection. Next group is COMT inhibitors. This drug levodopa can be metabolized by COMT in the blood vessels by the COMT. It can be inhibited by entacapone, tolcapone and opicapone drugs. That's why these drugs help in the increasing bioavailability of the drug levodopa. When this drug levodopa enters into the brain, it is metabolized into dopamine by dopa decarboxylase. This dopamine is metabolized by COMT inside the brain also, and this dopamine is metabolized by MAO-B also. To inhibit the COMT, tolcapone is a drug which can pass the blood-brain barrier and acts here, and these MAO-B inhibitors are selegiline to be given in low doses and rasagiline. Tolcapone is a drug, entacapone, opicapone. These COMT inhibitors, of them, opicapone is newly approved. They increase the bioavailability of levodopa. Side effects will be mostly nausea, this orthostatic hypotension. They cause vivid dreams, confusion, and hallucinations. Tolcapone is popular for hepatotoxicity. Therefore, it should be used only when patients are not responding to any other therapies. Safinamide is a selective MAO-B inhibitor. In selective MAO-B inhibitors, we see two types of drugs, reversible and irreversible MAO-B inhibitors. Among the reversible, we see safinamide. It is a novel drug. When combined with levodopa, it is effective in off periods. In moderate hepatic dysfunction, we need to adjust the dose of this safinamide. That's why it is contraindicated in severe hepatic disease. Coming to irreversible MAO-B inhibitors, selegiline and rasagiline. Selegiline, it do not cause cheese reaction. It is having some anti-apoptotic property. That's why we believe it is having some neuroprotective function. In early Parkinson disease in young patients, it is well tolerated for symptomatic treatment and off episodes also. In advanced Parkinson's disease, when taken along with levodopa, motor features and cognitive side effects which are seen due to this levodopa combination are more worsened. Oral selegiline, these tablets result in formation of amphetamine metabolites. These metabolites cause anxiety and insomnia. These orally disintegrating tablet or transdermal patch are also available. Irreversible selective MAO-B inhibitor, the selegiline rasagiline. Coming to the rasagiline, monotherapy in early Parkinsonism disease will be effective. In advanced Parkinsonism disease, when it is given along with this levodopa therapy, it reduces this off phenomenon. Selegiline or rasagiline, they cannot be combined with given along with meperidine. When they are combined with meperidine, they cause stupor, rigidity, agitation, hypothermia. Coming to the another group, NMDA receptor antagonists. Amantadine is a weak NMDA receptor antagonist. It acts non-competitively, used in early Parkinsonism disease in young patients. Its efficacy when compared with the levodopa, monotherapy of amantadine and monotherapy of levodopa is more effective than amantadine. Side effects of this amantadine will be libido reticularis and ankle edema, which are highly popular. Along with them, dizziness, lethargy, nausea, vomiting, and sleep disturbance also there. Istradefillin. Istradefillin, when combined with levodopa, they are effective in off periods. They improve urinary dysfunction, daytime sleepiness, cognitive impairment. Side effects are hallucinations, nausea, and dizziness. Some general points which are to be kept in mind while studying this Parkinson disease pharmacotherapy are: this pharmacotherapy of Parkinson disease are totally individualized. It varies from patient to patient, but they cannot alter the basic pathology of this disease. Levodopa and combined with carbidopa, it is a standard treatment, but the benefit declines after 2 to 3 years because it due to this varying of phenomenon. When these anticholinergics are used and selegiline and dopamine agonists, in early cases they are proven to be more effective. These anticholinergics but popular for side effects like sedation and mental confusion. Dopamine agonists, COMT inhibitors, they can reduce this on-off fluctuation. Some general points to be remembered are: in early Parkinsonism, early disease, when the disease in early stages, efficacy of this levodopa is more than non-ergodopamine receptor agonists, but duration will be less. Levodopa is more effective but acts for lesser duration when compared to dopamine receptor agonists. In early Parkinsonism disease, if it occurs in young patients, dopamine receptor agonists are recommended because if we give levodopa, we cannot avoid these motor complications. To avoid motor complications, dopamine agonists are recommended when the patient is young in early disease. When this early disease, if the patient is old age group, then we have to go for levodopa plus carbidopa combination. These impulse controlled disorders will be seen more in dopamine agonist group than levodopa. Acute off episodes. First line of therapy is oral dopamine agonists, COMT inhibitors. Next line will be injection apomorphine subcutaneous. There are surgical procedures which are under trial to treat this Parkinsonism disease. When we study this Parkinsonism disease pharmacotherapy, we should study Alzheimer's disease and antipsychotic drugs also. These three are somewhat overlapping to most of the students, so better study all these three diseases at a time whenever we study.